Thank you again. I'm really excited to be here. I want to thank the organizing committee, in particular, Dr. Sharif, for inviting me. I'm going to switch gears a little bit and talk about minimally invasive spine surgery in the pediatric population. This is sort of our clinical experience from when I was a fellow at Northwestern University, as well as now that I'm an attending at the University of Virginia. I have no disclosures relevant to this talk. Just wanted to spend a couple minutes talking about the concept of minimally invasive spine surgery, the evolution and the current concepts, examine the trends within the pediatric population, what indications are used in order to employ these techniques, and then our experience both from Northwestern and UVA. So what is minimally invasive spine surgery? I think we've all seen images like this before. To me, it really means approach or techniques that lead to a less morbid approach to the spine in order to achieve the same goals that open surgery can do. And so doing these things essentially means using a tubular retractor. So this is sort of a picture that explains or at least you can depict an open approach versus a minimally invasive approach using tubular retractors. Again, the goal is to try to do the same or achieve the same goals as open surgery using less invasive techniques. There's been technical reports described using microendoscopic techniques versus microscopic techniques. Again, I believe more accurately, minimally invasive spine surgery is defined by the use of tubular retractors and dilators. And essentially the goal can be to decompress neural elements or reduce approach-related morbidity. So who are good minimally invasive spine surgery candidates? As we all know, patients with clinical symptoms that are explained by perioperative imaging. There are certain patients who have comorbidities that prohibit extensive surgical procedures. They're also very good candidates. And candidates of any age, there's benefits shown in the elderly population as well as in the obese population. And so I want to talk about really, can these techniques be employed in the pediatric population? The less invasive techniques, there's been many reports in the literature about using muscle splitting and tubular dilators to minimize disruption of paraspinal musculature, and that can achieve very good postoperative results that lead to less blood loss and shorter hospital stay. These retractors can also provide direct and focal access to the diseased anatomy as well. There's certainly risks. There's risks to any type of procedure, but I believe with the use of tubular retractors, there's similar risks in open procedures. We'll talk a little bit more about that. Certainly there is a learning curve associated with these types of techniques. The more you do, the better the workflow and the risk profile as well. Talking about the disadvantages of open techniques, as we all know, muscle injury, blood loss, muscular and bony instability, the role of postoperative pain, increased narcotic medications, longer hospital stay, and infection rates have all been described in the literature. These are just a sample of reports in the literature describing muscle injury, even leading to decreased cross-sectional areas of the paraspinal muscles. And I think, after a while, that does have some effect, certainly with recovery, as well as with repeat surgeries as well. So what are the indications of these techniques? We know that there's the traditional indications, including lumbar stenosis, disc herniation, spondylolisthesis, and neural compression. But really, there are pediatric indications as well, including spinal tumors, tethered spinal cord releases, pars defects that need surgical interventions, as well as scoliosis. Just talking a little bit about disc herniations in the pediatric population, certainly they occur less frequently than in adults. Anywhere from 0.5 to 6.8% has been quoted. Europe has great record keeping in terms of medical records and health outcomes. A Finland study of 12,000 babies that were followed from birth to 28 years of age showed that there were no hospitalizations related to disc herniations until the age of 15. Still then, about 0.1 to 0.2% of subjects were 20 years of age. By age 28, 9.5% of males and 4.2% of females are found to have disc herniations. The pathophysiology is also different compared to the adult population. They're more so related to trauma. They can be sport-related, heavy lifting, as well as flexion extension injuries. As well as genetic factors with patients or pediatric patients with first-degree relatives. The largest series of lumbar microdiscectomies in the pediatric population is from Boston by Mark Proctor's group at Children's Hospital Boston. This was a retrospective review that was published in 2010. Again, it was the first surgical series describing this. There were about 87 patients that were treated between 1999 and 2008 with a mean age of 16. Interestingly, 60% were female. The duration of symptoms were about 12 months prior to surgical intervention. You can see the OR time was about 2 hours with a length of stay of 1.2 days. 6% of this population needed repeat surgery, with one patient ultimately needing a lumbar fusion. Complication profile was relatively low, with one patient with an infection and a couple with CSF leaks as well. So can this, the concept of MIS approaches be used for pediatric patients? I would say yes, depending on the indications. The surgical technique, as we all know, is similar to adults. I think also what's important is the use of a contralateral decompression or from a unilateral approach, especially for midline tumors that need to be resected or for tethered cord releases. It's important, and these are just pictures depicting that. These are just images describing the various surgical approaches using tubular retractors. Now, looking at the complication profile in the adult population, you can see that durotomies, epidural hematomas, facet fractures, and infection and instability are all possible. But again, this probably has to do with the learning curve and decreases over time. So what have people been doing in terms of minimally invasive spine surgery in the pediatric population? This was one of the first case series of 6 patients published in the Journal of Neurosurgery of Pediatrics by Dr. Jay and his colleagues at the Texas Children's Hospital. They had 6 patients who had disc herniations that were treated through a tubular retractor with good follow-up and good outcomes. Recently, just this year, Sandy Lamb, also from Texas Children's Hospital, who recently moved to Chicago, had a retrospective review of tethered cord releases, 11 patients, and they compared this with age-matched controls who underwent open tethered cord releases. The average age of this patient cohort was 10.1. They experienced no dural leaks, and then the statistically significant differences were a lower blood loss and a lower length of stay in terms of using these tubular retractors. Another method of using MIS techniques deals with pars defects. This was a paper out of Hopkins in 2008, 5 patients who underwent these hook and rod constructs in order to treat pars defects for back pain. All of these patients ended up being fused when looking at their postoperative CT scan. You can see on the right side. Again, good results. Dr. Levy's team in Florida used tubular retractors and to repair the pars defect using Buck's technique. 3 patients, again, with good outcomes as well. So we wanted to take a look at our case series as well. So essentially, we looked at clinical data for all patients under 21 who underwent these types of surgeries between 2010 and 2019. Again, in cases where tubular retractors were used, and then we looked at the demographics, symptoms, and clinical outcomes. So you can see here there are a total of 24 patients, 9 males, 15 females. The average age in our cohort was 15 years. 14 underwent lumbar discectomies, 13 1-levels, and 1 2-level case. There were also bony tumors that were present in the cervical, thoracic, and lumbar spine, where we used tubular retractors, 5 tethered cord releases, and all good outcomes based on McNabb's criteria. This is just a case illustration of a 16-year-old who had refractory right leg and foot pain for 1 year. As you can see, the disc herniation at L4-5. This was a 12-year-old boy with 3 months of persistent back pain with a bony tumor at T10. You can see here, tubular retractor was used in order to resect that lesion with no recurrence thus far. Just a short video showing an 11-year-old girl who presented with lumbar back pain as well as urodynamic studies that were abnormal, concerning for tethered cord syndrome. And you can see a tubular, an 18-millimeter tube was used in order to do the durotomy. And then eventually, it's very tight spaces. Obviously, it can get frustrating at times, but certainly possible with patients. The phylum is carefully dissected out and stimulated to confirm no neural activity, and then eventually sectioned. What makes this a little more challenging is closing dura within the tube itself, which can be done primarily with sutures, but there's also anasta clips, if you've heard of it, can be used very easily and very quick to close the dura, especially through a tube. This is just comparison. The first time I used it was in fellowship, and there was a paper published in 2010 by a group in Wisconsin, kind of comparing or detailing their use of anasta clips. 26 patients who underwent 27 operations for spinal dysraphism, syrinxes, dural tears. Again, good results with no leaks. Postoperative images, if you need to follow for tumors or other cases, very little artifact. So this is just a summary of our cases. Again, 14 discectomies, 5 spine tumor resections, and 5 sectioning of the phylum. EBL is very minimal, length of stay, usually less than 2 days, with no complications. This is a summary of all the reported MIS techniques in pediatric patients. The one of note is Menger and colleagues in 2018. They did discectomies on 16 people with an average BMI of 29.4. Certainly, as we know, in adult populations and obese populations, it is very beneficial to use tubular retractors in those cases. So just some technical pearls. I think the use of 18 to 20 millimeter tubes is pretty adequate for pediatric patients. We do all our drilling with the intact ligamentum in order to prevent durotomies from the drill. Liberal use of bone wax for hemostasis. You can always rotate the OR table to optimize the light and line of sight. Using curettes to release the ligamentum. And then we found that patients, this is a really good technique for patients who are greater than 7 years old, or and with 3 centimeters or more of subcutaneous tissue, just for docking reasons. Again, conclusions, sort of what we all talked about previously in terms of the use and effectiveness in MIS for pediatric patients, minimization of normal anatomy, reducing blood loss, OR time, and hospital stay. But with such a small number of patients, I really think that prospective clinical studies are needed in order to really understand the benefit in the pediatric population. Thank you.